Welcome back to the Rebel Core Content Podcast. Core content for anyone, anywhere, and just in time. This is Swami, and today we're going to talk a little bit about imaging in renal colic. Kidney stones or renal colic, ureteric colic, whatever you want to call it, is a common presentation to the emergency department. They're also a common driver of imaging. We all know what the typical clinical scenario looks like. Patient comes in with severe, sharp pain, radiating from one side of the back to the groin with dysuria, hematuria, and the pain is usually intermittent and accompanied by nausea and vomiting. The common pathway is to administer analgesics, antiemetics, and then obtain a CT scan to confirm the diagnosis. But many of the CTs we order are unnecessary and expose the patient to radiation while incurring more cost and producing longer ED length of stay. The question then is who needs advanced imaging and what imaging should be obtained for most patients. Now, before we get to specifics, it's important to start with the concept of why we're imaging in suspected renal colic. From an ED perspective, we shouldn't be imaging simply to confirm the diagnosis. Renal colic is a clinical diagnosis looking for all the things we mentioned above. While it's really nice to get the CT scan, confirm your suspicions, we shouldn't be doing this in most patients. We should be pursuing imaging mainly when there's diagnostic uncertainty to ensure that the patient doesn't have a more serious diagnosis. The presentation of renal colic is classic, but there are some mimics that we need to keep in the back of our mind. The most important is acute aortic pathology. We're mainly here talking about abdominal aortic aneurysm or AAA rupture, but we also have to keep dissection in the back of our heads. A 30-year-old man with sharp pain radiating from the left flank to the groin with hematuria and vomiting is renal colic. A 75-year-old man with the same presentation has to at least be considered for AAA and dissection. The imaging in the latter patient confirms the diagnosis of renal colic and makes us reassured that we haven't missed something serious. Of course, there are lots of other presentations that require us to consider imaging, and fortunately, we've got a fantastic paper to help guide us in that decision-making process. Imaging in Suspected Renal Colic, a systemic review of the literature and multi-specialty consensus. This was published in the Annals of Emergency Medicine in 2019. While this is a 4-year-old publication, I think it's important to review, and I find lots of people really aren't aware of it. For this publication, a group of ED docs, radiologists, and urologists gathered to review the evidence and then give recommendations, and it will simultaneously publish in all 3 disciplines' journals. That gives it a ton of power to influence our decisions. After reviewing all the literature, the group created 29 common scenarios or presentations and voted on what imaging they would recommend. In each scenario, the multi-specialty panel had a choice of no imaging, POCUS, radiology performed ultrasound, reduced radiation dose CT, standard non-con CT, or CT with IV contrast. They then looked at agreement between the docs to assess the consensus. Let's look at some of the themes that emerged. For young male patients, if they had classic symptoms with a prior history of stone, they recommended no imaging, or you could do a POCUS. Ostensibly, the POCUS was to look for hydro. Interestingly, they had 2 subsequent vignettes where in one, POCUS showed hydro, and in the other, it didn't. In both follow-up cases, the group agreed that no further imaging was necessary, raising the question of why do the POCUS in the young patient with a history of stones at all? Either way, simply finding hydro doesn't mean you need to change the way you do additional imaging. In the same age group, if there was no history of renal colic, the group agreed that POCUS would be a good initial test instead of jumping directly to CT. Progression to reduced dose non-con CT was recommended if the patient had refractory pain to typical analgesic regimens. However, the presence or absence of hydro once again didn't really influence the decision to progress to additional imaging. For young female patients, the recs were slightly different, and I think the reason they're different is because it's taken into account the pelvic organs, especially the ovaries, and the fact that ovarian torsion can mimic as renal colic. If they're young with typical symptoms and no history of kidney stones, the recommendation was for an ultrasound, either POCUS or going to the radiology department for that ultrasound. I think it's reasonable here to get the radiology department ultrasound, especially if you're concerned for alternate pathology like torsion. There isn't a specific case of a young woman with a history of kidney stones in the past. In that group, I tend to do POCUS, but I think it'd be reasonable once again to get that radiology department ultrasound if you were worried about torsion. Moving on to the older age groups, this group grabs all of the patients between 55 and 75 and lumps them into that older category. Now, there's going to be some judgment here based on the patient's comorbidities. We all know that there are 50-year-olds who look like they're 75, and there are 60-year-olds who look like they're 30. So take all of that into account. But I think in general, we're going to group together that older group as anything over 55. So in this older subset, if they have classic symptoms and no history of stones, the group thought that CT should be obtained. The type of CT varied a little bit between reduced radiation dose, regular non-con CT, and there was a minority of the docs in this group who said, let's get a contrast-enhanced CT, again, ensuring that we're not looking at a leaking AAA or a dissection. What wasn't really addressed well, unfortunately, was what to do with the older patient with classic symptoms of a stone, and they've got a history of stones in the past. My practice has really been to take into account how long it's been since they had other imaging. If a 75-year-old patient who's got a history of stones and tells you that their last stone was in their 30s, I'm going to get a CT today because that is enough time that we're worried about development of a AAA or some other pathology. If they had a stone a month ago and they're coming back, I probably won't do a CT in that case. In that case, I'll probably do an ultrasound. I might even look for the aorta with the ultrasound, although again, if they had a scan a month ago and their aorta was normal, it's unlikely that I'm going to find any pathology today. So that's kind of my approach, but this group didn't really give a recommendation. Overall, what we see in this article, as well as what we should see in clinical practice, is that it's reasonable to be more liberal in getting advanced imaging in the older group of patients because we're worried about those other pathologies, especially aortic pathology, and we're less worried about the effects of radiation. There's a couple of big take-home points for me in this article. The biggest is that patients with ureteric colic don't all need CT scans. We have to remember that our job isn't to clinch the diagnosis with imaging, but rather to use imaging to reduce or eliminate the risk of concerning pathology when it's suspected. 30-year-olds don't tend to get aortic pathology all that common, so we probably don't need to go after that group with a CT scan unless there's some other clues pointing us in that direction. POCUS and radiology ultrasound is extremely useful and can save select patients from ionizing radiation exposure, and some patients are going to be fine with no imaging at all. This is a short paper, it's definitely worth a read, and it's a possible discussion with your ED group, as well as radiology and urology, to come up with a nice little protocol. That's all for the Rebel Core Content Podcast this week. We'll be back in 2 weeks for another cast. In the meantime, don't forget to hop on over to the site, check out all the great posts from our faculty, and until next time, stay safe.